Hey there, because we're interviewing a doctor today, I wanted to give you the following disclaimer. The content of this podcast is for informational and educational purposes only. The views and opinions expressed are those of individual guests and do not constitute medical advice. Always seek the guidance of a qualified healthcare professional with any questions you may have regarding your health, medical conditions, or treatments. Never disregard professional medical advice or delay in seeking it because of something you heard on this podcast. And also, if you are enjoying the content in this podcast, please tell others about it, like it, share it, and follow us. Just really helps get the word out. Thanks. Hello, everybody, and welcome to today's podcast. We have a special guest with us today, and his name is Dr. Aaron Weiner. He is a board-certified psychologist and addiction specialist who works nationally on addiction, behavioral health, and drug policy's impact on public health. His expertise stems from directing hospital addiction services and observations from private practice, combining clinical experience with current research. A past president of the Society of Addiction Psychology, Dr. Weiner serves as an addiction policy advisor for the American Psychological Association and on the Science Advisory Board for the Foundation for Drug Policy Solutions. His insights have been featured in Newsweek, USA Today, the Chicago Tribune, The Guardian, Psychology Today, and New York Times. Welcome, Dr. Weiner. It is so nice to have you. We are going to talk today about levels of care, because I get into that as a coach or somebody who licenses to coaches. I want people to be aware of when somebody might need something different. And I want people to develop an awareness of where are they on the spectrum, because some people can have a problem with what I call this habit with one or two drinks a day. And sometimes that needs a higher level of care and sometimes it doesn't, right? We're all unique. And just thank you for joining me today to talk about this really important subject.
It's my pleasure, and I'm excited to talk about it, which sounds strange because levels of care sounds incredibly dry, but I actually think it's very interesting. It's also really critically important to understand the landscape because so many people, when they develop this problem, they walk in and they're just lost and they're like, where do I go? What do I do? I'm seeing all these advertisements and predatory ads that say one thing or another, or people who are like, oh, this is the only way to do it, and it can be very confusing. So I think talking about levels of care and what the options are is actually really critical.
Yeah, and so let's just start with the lowest level of care. And I'm just going to throw out what I think is the lowest level of care. Buying some books, right? And getting educated about the problem. And I love, as you do, this is why we connected at a conference, but I love looking at the science because it takes away the shame. And buying books and getting educated on, how neurological pathways get created, what dopamine is, all kinds of things. It helps take the shame away because that's how we're built, right?
Oh yeah, definitely. Well, and I think that sort of do-it-yourself side of things, right? When we think about tiers in service delivery, right? You've got the do-it-yourself tier, you've got the do-it-with-you tier, and then the I will do it for you tier. And unfortunately, that last one doesn't work with addiction recovery. No one can do that for you. Someone always does have to be part, but there's different levels of support. And I think one of the biggest misconceptions is that people that don't realize that most people who develop some type of addiction or substance use disorder is our technical term for it. They recover actually without going to formal treatment at all, or even
Mhm.
sometimes peer support groups. It's really just they realize they need to make a change. They might buy a book or have come up just decide that they're going to go in a different direction, and then they are able to do it. even if they're facing some structural challenges from, say, like within their own biology or in their environment, they're able to get the job done. And sometimes just having that guide, like a book in your hand, or the information to understand, like how does the reward system work in the brain? You mentioned dopamine, or how do triggers and cravings and more of these substance-related processes work, and how do you manage them? And that information alone certainly can be enough. For some folks, though, and I'm sure we'll get there, they need an extra level of support.
Yeah, and I think the extra level of support is accountability, which personally, I don't think it's, again, my opinion, but it's difficult to get this problem solved in your own head. There has to be some level of what I call bringing the struggle into the light, which is the unfortunate part of stigma, right? We keep this in darkness in our head and, swirl around but accountability is definitely a level of care or support. In this case, support. There's lots of groups and coaching and online things that provide that accountability. I even see in my groups where a spouse can be a really supportive system. That, honey, I'm trying to quit drinking, and people will tell me my spouse was so supportive, but that's because they had knowledge, they had done research, this and that and the other thing. And now we get into, and so we're going to keep graduating up, right? And now we get into people are always, this is human nature, right? We need to fix it ourselves, right? We're not going to, go out of our comfort zone. Like, I can fix this, I can do this. And so I have a lot of people in my private Facebook group that have the devotional, they're trying to do it themselves, but they're stuck. And so now we graduate to coaching or counseling, which are two different things, I know. So since you're a psychologist, let's focus on the counseling thing. Unless you have an opinion about the coaching aspect, because I just think that's one level of accountability that might work. Do you have any opinions on the coaching side of it?
Yeah, well, and I think as we talk about this, I want to add in, I think accountability helps, but also structure. And I think that's where coaching absolutely can do that. And actually, as we go up in the tiers of care, we're going to see that structure increase in a few different ways. And some folks, they need that. They either need the structure of a program or a workbook, or of accountability and structure of just having another human being there with them,
Right.
checking in with them and being present. So I think so in my mind, where coaching, particularly coaching when you're not working with a therapist who's doing coaching, but working more with a coach, and therapy diverge, is that therapy has more to do with evidence-based practices and emotional work, that may span outside the here and now and may go back in time by a lot, or may require some of the extra education and supervision and learning that comes from getting an advanced degree in an applied behavioral
Mm-hmm.
health field, versus something that's much more focused on what is in front of you, what you can see, how you're oriented, mindset, current focus work with coaching, not necessarily going into like therapeutic principles and modalities and all that jazz. So I definitely think that there's a place for recovery coaches, for coaches more generally, for sure. I think that they go in just different directions. And a theme that I'm sure we'll come back to a lot today is that what any individual needs is a very individual decision, and it takes a knowledge or awareness of where are your barriers and what's going to help you overcome those barriers. What
Right.
resources do you need?
And I love that. And that's what I've come to understand too, in terms of coaching and counseling in my own um, uh, kind of walk in this journey. And the American Association of Christian Counselors has helped me understand this too, that coaching is really moving a person forward. But when they're stuck and they can't move forward, that's where they need maybe the assistance of a counselor. So let's get into that because that is, you know, that is your expertise. That is where I see people getting the most stuck. I think the majority of people, I don't know if you have percentages, I'm going to just go with what I've kind of seen, that are really committed to this process and maybe are willing to invest in themselves. I've seen between 75 and 80% success rate. Um, that they can do that without the professional counseling. Now, I wasn't one of those. I needed years of therapy. I needed some EMDR uh, work. And let's talk about how maybe a person should understand um, or what kind of mechanisms that they need to come to terms with that says, I need a little bit more, and this is going to help you. That's what I want to tell people. It's not a bad thing. Let's just get this solved because life is so much better on the other side.
Right, right. So here would be my take, and I'd love to get your thoughts on this. But the way I would look at it is the proof. The proof is largely in the pudding. So if you're trying something, if you're trying an intervention, like you've bought a book or you're working with a coach and you're finding that, or even a therapist for that matter, but you're finding that what you're doing is not working and you're stuck. You've been going at it for at least a couple months, like say like 2 to 4 months, and you're like, I'm not achieving the results in my life that I want. I think a lot of times people might take that personally and say like there's something wrong with me or like which is usually not the case. Usually the case is that there's some element of this that's not being adequately addressed by the resources that you're utilizing and or the situation that you're in, and you need to change something so that you address that problem, and once you do, it can get better. Now, from the therapy side, really, in my opinion, particularly at the outpatient, so just like seeing a therapist once a week, say, for example, something like that, um, what that taps into that might be for many people a stumbling block is the element of coping. So how are we dealing with whatever it is we're carrying, whether or not it's internal concerns like trauma or depression, obsessive compulsive disorder, whether or not it's external concerns, like if someone's in a toxic marriage or relationship or in some difficult life circumstances, they're working 80 hours a week at a job and have no room to think and are just trying to like down-regulate themselves at night, something like that. But sometimes people are caught in patterns with their feelings and with their behaviors that are just very difficult to shake without diving into more of those evidence-based approaches, like EMDR, that's eye movement desensitization reprocessing, or there's a lot of other types of very therapeutic clinical approaches that help with specific types of emotional concerns or behavioral concerns. And so I would say like when to tap into a therapist. I think if you're finding that you're stuck and you can't even really put your finger on why, or you can put your finger on why, and it seems like what you're doing isn't getting you there, that's when you take that step.
Thank you for sharing that because I always try and say the definition of insanity is doing the same thing over and over again and expecting a different result. And the problem with um, it when it comes to substances, instead of just looking at it as a fact set, we start thinking that there's something wrong with us. And we're irredeemable or unfixable, which is the shame aspect. And digging yourself in shame is the worst thing you could do to fix the problem, right? And and so I appreciate you sharing that if you're doing something, it's not working, I need to try something different. Um, and that really is the answer. So
If I could share a quick anecdote as well, and this is different for everybody, but I'm thinking there's a gentleman that I was working with where he wanted to eventually quit, but at bare minimum cut down his alcohol use, and had tried so many different things separately, and then even with me over several months. But an option that he'd been very resistant to was using one of the FDA-approved medications to help with this. And it's not right for everybody. I want to put that out there as well. But just in his case, he eventually did decide to try naltrexone. which
Mhm.
reduces cravings and reduces the amount you drink by changing the amount of reward you feel when you drink. So it doesn't feel as pleasurable. And the results were amazing. There was almost immediate change. He's gotten to a point now where it's been basically 2 months. There's been no episodes of binge drinking. It's been, it's things have changed so dramatically. And for him, there was just a biological element that was so difficult for him to manage with all of and he was throwing at himself at every, this wasn't someone who didn't work in therapy. This was someone who was really trying his best, but his biology was working against him so strongly that was the missing link. And you put that in there, and now all of the other things work so much better. And
Right.
again, to underscore, that's not to say everyone should use naltrexone or that everyone needs to use a medication, but everyone's circumstance is different. And if you're giving something a fair shake, because I do think that practice matters. It's not just, if you try something once and it doesn't work, don't try it again.
Oh,
But if you
yeah.
really give something a fair shake and it's not working for you, we have a lot of tools on our belt to draw on. It's sometimes just a matter of finding the right one for you. There's nothing wrong with you.
Right. Yeah, I appreciate you saying that too, because it's got to be a fair shake, right? And I tell people, well, in our program, right, it's let's give it 12 weeks and see what happens. But in like group settings, if they drink twice during that 12 weeks, I lovingly share with them that I prefer them not to do it a third time because I don't want them to practice, saying I can't do it. I want them to consider a higher level of care. Because I find that, well, 100% of the time, if I allowed it again, it would happen again, right? So that's kind of where one time is, it happens. It's just part of your story. And then two times, maybe we ought to just see if there's a different aspect of, that we should incorporate in here. And yeah, the thing that I really struggle with is the people that stay in the books. They want to read another book and another book and another book and another book and think that it's going to fix the problem. And if you really want something to change in your life, I just really encourage people to look at alternatives like seeing a counselor. And so one of the things that I loved about another clinical psychologist that I interviewed was he said something to me, and I say this all the time now. I I was using um, alcohol as my medication. Like I was medicating myself to because I didn't have any other way to cope with what I was going through. And that happens a lot, doesn't it?
Oh, yeah. I mean, I'd say upwards of 95% to 99% of the time. I mean, there have been some very rare cases that I've seen over the years where it's just simply somebody is drinking and can't stop. Usually the reason why they can't stop is because it's serving an emotional purpose. And that feels they just don't want to feel the anxiety or the depression, or they feel like they just can't tolerate it. And this has been their lifeline. And they've been, you repeated behavior also, like you do this for years. I mean, think about how many thousands or tens of thousands of times you repeat, I feel a certain way, therefore I drink, or I don't feel better yet, I drink more. That's a really ingrained habit. It doesn't change overnight. It doesn't necessarily change easily, but it's rooted then in that emotion.
Tell me about it. And then we talk about how much stress is in this world every day. Just even the AI stress, right? I got to keep up. I got to keep up. I got to go faster. It's like, I think we need to live in a world out where we need to slow down. I've shut off all my TVs because I've learned to understand without the substances. I've learned to understand the physicality of my body, and I can't stand stress.
Yeah.
Imagine that. Like, I used to think it was a healthy way to like go up the corporate ladder, right? And the other thing about stigma, and I'm sure that you can concur with this this problem has no boundaries in terms of economic and social, and because my first entry into this is into the executive world. That's where I started. That's where I got healed. That's where I started. There are a lot of very high profile, successful people struggling with this, right?
Oh yes. No, I've to be honest with you, I've worked with all sorts in my career. I spent time at the beginning of my career in VA hospitals where folks we had one walk of life and not very much money, went to a public hospital system where I worked with a lot of folks on Medicaid, then went to a private hospital system, and now I'm in private practice out of network, and I frankly see people with the means to work with me out of network. And it's everybody because stress, coping, and emotions are ubiquitous across all walks of life. Your job title doesn't save you from that. Your money doesn't save you from that. The set of clothes changes, right? Like what people are stressed about, what hurts them, the threats that they face are different at different walks of life. But the human experience is the same, essentially.
And so when you're seeing people as a clinician, what types of things are you working with them on? How long does, we don't, well, I was in counseling for 3 years. I don't want to discourage people, but, if there's a specific goal, what kinds of things are you doing with people that come to see you?
Yeah. Well, so I would say that there's a couple of different prongs that we work on. One prong is the substance itself, and there's some education around what is a craving trigger, how do you make it out the other side, what's going on in your brain and your biology, how do you work with that? There's all that side. But then there's the emotional side too, because they're almost always intertwined. And particularly when someone chooses to see a therapist, or certainly a specialist like me, there's again, 99.9% of the time, there's some sort of behavioral health or psychiatric issue going on as well that needs to be managed and isn't being controlled. And that's what the substance use or gambling or sex, and it's not just substances, it can be other things
Right,
too.
right.
What that's all about. And so for me, the way that I normally work, I would say that active treatment, where I'm seeing someone every week, sometimes more than once a week, but usually once a week, pretty good cadence, is I'd say like 6 months at the far end. Oftentimes it's closer to like 3 or 4. And by that amount of time, if we haven't made significant progress, it's usually because, honestly, it's usually because folks aren't either applying themselves between sessions because, and I know we're going to talk about higher levels of care too, but when you're seeing a therapist, your week is a lot longer than 1 hour. I get someone usually for about an hour a week. Most of your life is not with me. And so the purpose of therapy is to develop uh, tools, skills, and a mindset that then you practice and apply. And then you come back. And just like with physical therapy, where you build each week, that's how therapy should work and feel. And most modern therapeutic protocols, aside from one type of therapy called psychoanalysis, which is designed to take a lot longer, but other than that, uh, you can get through it within 4 months, in terms of what you're trying to work on.
That's
And so,
awesome.
yeah,
And
yeah.
that would
So,
be when I did my EMDR, it was definitely inside 3 months. I was surprised at how quickly it worked, for me.
right.
Um,
Which isn't, I'm sorry, go ahead.
no, that's it. I was just really surprised at how effective it was for me. That was a linchpin that I needed. So,
Right. Well, and that isn't to say then, though, that there aren't still things to talk about afterwards or that there isn't other work to do or you don't set a new goal and go after that goal. But maybe a better way to put it is that if you haven't made significant progress towards a goal that you've set within certainly 6 months of working with a therapist, it probably means that you either need a higher level of care or a different therapeutic approach or a different therapist. That would just be my 2 cents.
and tell me, this is a really important question for certainly my audience. What should I look for in a therapist um, when I know I'm sure that I just can't get a handle on this? I think it's my anxiety or my depression or my OCD or. Um, how do I find the right therapist? What do you think are the most important things to look for?
That's a really important question, and I will be happy to answer it with my thoughts on that. Um, and before I do, I just want to addend my last comment and say there are some problems that take longer than 6 months, and so I definitely
Abs-
wouldn't want someone.
3 years.
Yeah, yeah. For someone to think like there's either something wrong with me or I've got to ditch my therapist. Um, and some people have really like long-standing complex traumas, so it's not to say that there aren't some exceptions, but just again, my personal work and my experience has been that even in tough cases, if I don't know, just my personal morals. If I'm not helping someone in 6 months, I gotta really check myself and be like, is this the best fit for them? But in terms of what to look for, there's a couple of key things that I think are really important. And I'm saying this with finances not being withstanding, because obviously, if you need to work with an insurance network, we got to do the best that we can do. But um, the number one thing is that you feel like you like and respect your therapist and that you can be open with them. The therapeutic rapport across all the data, your ability to feel connected and open and vulnerable, and that you respect your therapist is far and away the most important thing, more than any certain type of therapeutic modality. So that first and foremost. So if you don't, if you have an intro session with a therapist and you're just not vibing with them or you don't feel like as comfortable as you can be, I know some people are going to be uncomfortable no matter what. So, have it be within your range of experiences, but just make sure you feel like, yeah, like I like this guy, I like this girl, like I think that they can help me like that. That should definitely be there. One. Two, they need to have the expertise for the problem that you're there to work on. And that is also important. If someone doesn't act, so my license, like I'm a licensed clinical psychologist. With that license, I can bill insurance for treating someone with low functioning autism.
Hmm.
I have no idea what I'm doing. I would never accept that person. But if I did, I could say that I'm working with them and I could collect money for working with them and legally bill insurance for that. Our licenses are so broad. And we can market ourselves even in ways that are disingenuous. Not to say that there's a lot of like therapists out there who would do that, but there's a lot of people who might think they know what they're doing, but don't actually know what they're doing in some cases. And so I'm a big fan of asking some pointed questions about like what types of therapy people are doing and making sure that you go in ideally with an idea of what good therapy looks like for the problem that you're working on. I'm a huge fan of credentials. So like I did take the step to be board certified in counseling psychology because I think that people assume that behavioral health practitioners that there's some check on their skills. There's not actually. Like in medicine, virtually everybody's board certified, which means you stand up in front of a board of your peers, you're evaluated not just on knowledge but also on skill. Behavioral health doesn't do that by default. In fact, the vast majority of therapists, we have to pass a licensure exam, which is a test of knowledge that we're book smart or that we've learned enough in school, but not of skill. So I took the step to do that in counseling psychology. I also have a master addiction counselor certification from a national organization that certifies addiction professionals because I think that's important. But there's a lot of people who will say that they work in certain areas or specialize in certain ways, and you just have to take their word for it. And they might be fine, they might be good, but I'm a big fan also of people who take the time to get certified in the things they say they're good at. And so if you have the ability to look for those certificates or credentials and addiction credentials, there are national ones, and there are also many states have their own addiction credentials that you can look for. So I would look for that too. And but much how like in this podcast, like I could very fluently talk about addiction and the science of addiction, what recovery looks like, levels of care. Your therapist should be able to do that too. Like if they know their
Yeah.
subject matter, like I don't know if you're listening to this podcast, I'm not looking off of a note sheet. Like this is just the ocean that I swim in. And this is
Hmm.
what any therapist in a specialty area should be able to do.
Right. I agree. I don't prepare for my podcast either. So I understand what you're saying. It's like
Yeah.
I know everything I know because it's secondhand nature for me. But yeah, I thank you for sharing that. And I agree that people need to know. But what if there's, and this is interesting and actually causing me to think a little bit too, because what if it's just trauma? Like I'm horrified at the amount of people that I became aware of that have been molested as children, and they use substances to deal with that. Would you say the trauma therapy expertise might be even a little bit more important in that case?
Yeah, so I have a little bit of a soapbox about trauma in particular, because so I spent 3 years in VA hospitals training, and they're very conservative there about what they will certify and allow practitioners to do because
Mm.
there's such a huge backlog of people who need help in the VA system. You can't afford to be messing around, and not helping people. And so there are certain therapies that have been shown through evidence to help. And I would strongly encourage someone to work with a therapist who works in those modalities. So the ones that have the best evidence are EMDR is one of them. There's three. EMDR is one. Cognitive processing therapy is the second. That's what I've been trained in, and that's what I do my trauma work in. And the third is called prolonged exposure therapy. Those are the three with the best empirical support.
Can
There
we
are
take
other.
a minute to explain those three things in brevity? But we should, because that will help people
Yeah,
who want to explore those things. Yeah.
yeah. So briefly speaking, so EMD, so all three of these therapies have their roots in cognitive behavioral therapy and exposure, because ultimately trauma is basically it's like almost like a metastasized anxiety disorder where you've had experiences that have created a lot of tension, fear, and adrenaline. And you need to change your relationship to the memories, and you need to get rid of the adrenaline response. And so all the therapies look at those two different elements and address them, but in slightly different ways. So EMDR, you're doing that cognitive work and the exposure work with basically what's called bilateral eye movements, where you move your eyes back and forth. And that's an element of that particular therapy that is not present in other ones. And bottom line is the therapy works. There's some mixed evidence on how much the eye movements actually matter, to be honest with you.
I did my ears, the beep beep in my ears. It worked really well.
Yeah. So it is a very evidence-based therapy. So, but regardless, that's how that one works, where you've got the bilateral brain activation along with the exposure and some of the cognitive work. Prolonged exposure therapy is one that's usually more indicated if someone's having a lot of adrenaline related and like the stress, like intense stress reaction responses. Uh, if that's really like their more primary symptom, that's where sometimes people will go. Prolonged exposure really leans into the exposure, where essentially people who have trauma spend a lot of time usually avoiding reminders of their trauma. They don't want to think about it. They don't want to talk about it. The problem is, though, that it lives in their mind. And a lot of times there's also triggers in the outside world, so that ends up not working so well just by trying to avoid it all the time. And prolonged exposure is like the opposite of that. You are exposing yourself to the memory pretty much every day because you record yourself talking about it, narrating it, and then you listen to it all the time. And what that does is it's a very intense deconditioning routine where eventually that memory stops being triggering in that visceral way because you've heard it so many times. It's just like a really awful story. But you don't have the adrenaline response anymore. So there's still some cognitive work, but that one's very heavy on the exposure, a lot less on the cognitive. Cognitive processing therapy, as you could probably ascertain from the name of it, leans a lot more on the thought work and does exposure, but that's about 15 to 20% of the time. Whereas most of it has to do with the lessons that the trauma teaches you. So say for example, your trauma teaches you that nowhere is safe or you can't trust anyone. Well, those are beliefs, those are thoughts. And when you take that thought and you put it on your life now, where maybe there's a lot of trustworthy people who could be supports to you, friends, even love you, because you're thinking, I can't trust anyone, or I have to push people away before they hurt me, your life becomes very small. And so CPT really leans a lot, cognitive processing therapy, into that thought and learning side. And how do we figure out these beliefs that are driving you to act in certain ways and start to challenge and change them into thoughts that are more accurate and adaptable, or excuse me, adaptive.
Yeah, I love it. The cognitive part is where we overlap a little bit because I do a lot of work in just trying to find truth. Like identify the story that you're telling yourself, identify if it's true, and then reprocess, and then practice it, practice it, practice it, because it takes time. Um, and and I didn't ask you about your background in addiction or if you have that yourself, but look, I drank for 40 years. I had some really ingrained bad habits. And and I look at a glass of wine sometimes at dinner, and this whole romantic picture comes up for a second. And then I have to remind myself, like, wow, that's a lie. It's poison. It's not good for me. I know where it's going to go. No, thank you. And I redirect. And that's the end of it. Now, did it start that way or that easily? No. But I tell people and they laugh, but it's true. I have a bigger problem with chocolate cake than I do with wine at this point, right? We all have to make choices and we want to take the time to process our choices before reaching. And so there we can talk about connecting, right?
Yeah, yeah, absolutely. I don't personally have a history of like a substance use disorder or anything like that, but I have absolutely, I'd say if I had anything, it's funny you mentioned chocolate cake. There was a while there where every night I would be eating too many chocolate chips because that was just, I love the taste. I've got this brand I really like, and I was gaining a lot of weight and it wasn't healthy. And for me, this is a great example, right? It's obviously not as chemically entrapping as other substances, but I just decided one day, I am not going to let eat myself eat chocolate chips as a snack for fun, for pleasure, more than once a week. That is it. That's all it's going to be. And I literally have done that to this day. That is still a rule I have for myself. I still sometimes think about like, I kind of want to have some chocolate chips. And I'm like, nope, I had my chocolate chips this week and that's it. So
I may try that once a week, a sliver of chocolate cake. That's it. I'm sure I can train my brain for that. So I'm still trying to figure out that part of my life. So it's always processing something, but that's life, and that's what I love those challenges actually personally. All right, I think last level of care, right? We need to identify going into a professional facility or maybe outpatient versus inpatient. Do we have to speak a little bit about both?
yeah, so we do break it down. So say for example, you're seeing a therapist or that outpatient, regular like outpatient therapist level of care, and you're not achieving your goals. After that, there's a lot of little steps, but there's basically 3 to 4 other steps that we should talk about, and I'll go through them briefly here, and we can dive into them how we'd like moving forward. So the first one, I'll actually start with one of the more intense sort of ones, just by facility standards, but it is detox. And sometimes people actually have to go to detox in order to stop using their substance. And that's oftentimes attached to a medical center in some way. Sometimes it's attached to a treatment center, but it's short. Usually you're in a detox environment for, call it like 3 to 5 days would be the normal, maybe 4 to 6 depending. But basically, as you come off of a substance, your body, if you're dependent on it, chemically dependent, it has to get back to homeostasis. And doing that sometimes is very uncomfortable, like say in the case of opioids or cocaine, or sometimes can be deadly in the case of a lot of alcohol or benzos, like benzodiazepines, like Valium or Xanax or Klonopin, that sort of thing. And so for some people, that's a step that they need to take to either do it comfortably or even safely in order to get to the next step. So I want to put that out there, because that is part of the levels of care thought. But if someone's actively using and they need to stop, sometimes that's their first step. Now, beyond that, there are 3 other ones. There is the outpatient level of care, where you go home at the end of the night and sleep in your bed. And then there's the residential level of care. Outpatient is divided into 2 different types. One is called an intensive outpatient program, or IOP for short, which is a minimum of 3 days a week for 3 hours a day. A lot of times, though, it's 5 days a week for 3 hours a day. Like you'll go all morning and you'll be out at noon, or you'll go in the afternoon, or you'll go in the evening after work. And then a partial hospitalization program, or PHP program for short, which sounds like you're in a hospital, but you're not. What PHP means is you're going 5 days a week, 6 hours a day, so 30 hours a week of treatment. But you do go home at the end of the day, 6 hours a day. So, um, what those programs consist of are a lot of group therapy generally, some case management where people try to help you get your life in order. They do have to have small amount of individual therapy, not too much, but some, could, I think, be half an hour a week. In the case of an IOP program, that's the 9 to 15 hours a week. I believe an hour a week of individual therapy in a PHP program. But most of the work you're doing is with groups. And then also, I believe in most states you do have to have a meeting with a psychiatrist as well, at least once or once a week, depending on the state and the program in those programs. So you're going to get the medication adjustment if you have needs for medications as well as part of that program. And the reason why you would go into those programs would be, one, if you're just not getting the results that you need from whatever level of care that you're at previously, but also having structure and community around you. Because you go into those programs, you can plan to be there for probably between 4 and 6 weeks total. PHP, the 30 hours a week, is usually no more than 2 weeks of that before you would what's called step down into IOP. So you might do, say, like a full day at the facility, like 8 in the morning till 2:30 or 3:30 for PHP, and then step down to just the mornings when you're ready to go to IOP. But all within, say, the same organizational structure. But the idea is, if your life has been totally based around drinking, say, you take that out, you're left with a lot of time or not a lot of structure, or sometimes just getting your mind in a recovery space for 6 hours a day clinically is what you need, because you've tried less than that and it's not working so well. So basically your day job is getting better. You're going in the morning, you're leaving a little before dinner time. That's your day. And then maybe you go to like a 12-step meeting or a smart recovery meeting or something else at night. Like it can be a very full court press in that way. IOP is half of that, right? You're just going in the morning or you're going in the evening after work. So you can see like what level of structure and support and community do you need, and then go seek that out. Now, above that, if that's not working because either the drug or the alcohol is readily accessible for you when you go home, or you're going out and doing it anyway, because again, you're in your environment, you've got the people around, you've got the cues around, you're just not able to control the behavior when you're at home. That's really what the residential programs are for, is they take you out of your environment and put you in a more controlled space. Not locked space, you can leave if you want to, but it's a controlled space where you are living at a facility where recovery is what you do. So at least for that period of time, which again is usually 4 to 6 weeks, usually more like around a month for a residential facility, you're not drinking, you're not using substances. You are thinking and talking about this all day, every day. Everyone around you is doing the same thing that you are. And it gives you space to build a new way of living and coping with your feelings and being separate from drugs and alcohol, to then transition back into your environment when you go home. And oftentimes, like the best case, like the best practice is someone leaves residential where they're thinking about recovery 24/7, and they step down to a PHP program where they're thinking about it for 30 hours a week, and they do that for like maybe a week or two. And then they step down to an IOP program where they're doing it for 15 hours a week. Again, usually that's at the same place. And then after that, they go down to just going to support groups or an outpatient therapist or whatever they feel they need. But it can sometimes be a huge shock to go from living at a residential facility to just going home.
And oh, so many people do that. And that's what I try and tell people, especially when we're talking about rewiring our brains. Like every season is going to bring its new challenges. Like stay connected to someone for at least a year in a group, or your spouse or whatever support system you need. If you want to be committed to changing your relationship with a substance for the long term, you need to stay connected and not go, like you said, from this is my job every day, all day, to here's my family and here's the drinking or the drugs in front of me or whatever. And
Yeah, here's the liquor store, and here's the, yeah.
it doesn't work. It doesn't work. So stay and certainly that's what I see, right? Because we get confident, like, oh, I feel better now. Let me let me engage again. And
Mhm.
these challenges are going to come until you literally develop stronger neural pathways about your thoughts about how you want to live your life moving forward. And yeah. So well, I think one of the last questions I wanted to ask you, we talked a little bit about this before we started talking, was, what percent, a great percentage of people that have, we'll call it alcohol use disorder for now, or substance use disorder. I don't know as much about the substance as I do about the alcohol, but a great number of people do not need medical intervention. Would that be an accurate statement?
Yeah, that's an accurate. I think there's probably more people who could use it who aren't getting it, to be honest with you, but it's not everybody, not even close. Yeah.
Yeah, that's what I think. And any thoughts on how to reduce stigma? It's a bugaboo, isn't it?
Well, so I think talking about it is the most important thing. I think that so it's a chicken or the egg thing, right? Because people are uh, they're reticent to share because they're worried about stigma and blowback and harm to them for being open. But then at the same time, the secret is part of what and the lack of understanding of what recovery is, what addiction is, what people are like who are going through that process is what drives the stigma. And so I think that as much for those who are willing to be open and be brave and just talk about it, like it's a medical condition, like in my opinion, it's a behavioral health medical condition. It's something where it's not a moral failing, it's not a problem with the individual, it's not a crime to have an addiction. Like I think, which isn't to say that there shouldn't be laws around, these sorts of things, but like I don't think that if someone is caught in an addiction that there's something inherently wrong with them. I think that
No.
they a behavioral health problem,
Well,
not
I
some
and
problem.
I think a vast majority of our population, well over 60%, if I add up all these other things like pornography and online gaming and gambling and substances and phone, like, right?
Yeah.
I mean, they're just all different levels of dopamine. So let's throw it all in a pot and call it, that's how we operate. We try and find things to relieve anxiety and stress, and they're usually, there's a level of dopamine and comfort associated with it, which is why we repeat the behavior. Um, no,
Yeah.
I guess I have one more question. What role does faith play in healing?
Yeah. Well, I know we talked about this earlier that it is so important to know your why and to know what your purpose is and what you believe in and that you feel like you're part of something important and bigger. I think that when people drift in their life, and whether or not that's faith in religion or whether it's for some people it's about their family, for some people it's about science, for some people it's but seeing your path, right? And knowing what your purpose is and what drives you. I think that's an anchor point that we can't discount. And a lot of folks, when they are trying to recover, well, they're like, well, why? Like, what's the
With
point of all this?
That's
You've got
exactly
you don't
where
need an answer.
yeah. And that is where I was, only I was faith-based when I was struggling. But it was like, why bother? I'm ready, God, just take me. And unfortunately, you get to that point. And yeah, just want to tell people there's no need because there is life on the other side that's wonderful, right? If people want to know more about you, Dr. Weiner, how would they find? I know you are big in the public speaking circuit. You also have a clinical practice. So how would people find out more about you and what you do?
Yeah, just swing by my website at weinerphd.com. That's the hub, and feel free to reach out. And anyone who's interested, I'm very responsive over email, on LinkedIn. That's where I post. That's the only social media I do is on LinkedIn, but I post there very often. I also have my own podcast where I've got some backlogs there that you can listen to if you're interested in any of the folks that I've chatted with over the years. But yeah, just head over to my website. Feel free to drop me a line.
Oh, I love it. Well, thank you for coming on. I thought our topic was exciting too. To people that just love helping people get out of this stronghold is what I like to call it. I don't know, maybe we haven't spent enough time, but I have a whole uh, new terminology, alcohol free, healing. I think like I'm trying to get rid of the terminology that is causing stigma. So we can keep trying, right?
Yes, the talking. I know it sounds like fluffy. We're like, oh, just talk about it, but it's that's where it's like stigma is a social construct. We change people's minds and hearts through information and experiences and exposure,
Yeah.
and that's honestly like it's a long task. No one person can do it, but as long as we all do our part, that's what gets you to the finish line.
Yeah. Well, again, thank you for being on. I'm sure this is going to help a lot of people decide where they are and what they need. At least that's our hope, right? All right.
Yeah, yeah. Hope so. Thanks for having me.
All right. Thanks.